Good morning, everyone. I think all of us have to thank Dr. Matthew John, Dr. Tichu Woman, and the Providence team for organizing this capsule CME and inviting all of us to be part of the same. Thyroid functions, newborns, interpretation, and decision making. This is what I am supposed to discuss in the. So, uh, all of us are aware of the unquestionable role of thyroid hormones in neuro and general development. But the benefits of treating mild TSH elevation as defined by values less than 10 is not very clear. And the most of the thyroid function abnormalities which we come across in the neonatal period relates to either increased TSH or low T4. So basically, we'll be mostly dealing with the realm of hypothyroidism, and neonatal thyrotoxicosis is a very rare problem. So the discussion will revolve around interpretation of thyroid functions in neonates, and in most of the cases, the decision to treat or to pronounce the thyroid function as normal is pretty straightforward. But in a significant number of cases, we'll have to observe and repeat the thyroid functions, and then the decision to treat or not to treat is made. So let's look at the evidence base for our current practice of dealing with thyroid function abnormalities in neonates in a structured fashion. We'll first look at the thyroid function interpretation in normal, preterm, and sick neonates. Look at factors which will help influence decision making, rather factors which actually increase the probability of having actual thyroid related disease state. Guidelines, there are two guidelines which have come up in the last 10 years. The European Society of Pediatric Endocrinology Guidelines 2014, which has heavily influenced the Indian Society of Pediatric and Adolescent Endocrinology Guidelines 2018. There are these helpful ancillary tests like, for example, the ultrasound thyroid, which helps in decision making. So we'll look at those very briefly, and then also the two enigmatic rare entities of late onset and transient hypothyroidism. All of you are aware of the high T4 TSH surge which occurs immediately after birth, which lasts for around 72 hours. For this reason, it is always best to do the thyroid function at least after 48 hours, preferably at 72 hours. This surge is rather attenuated in premature babies, as you can see, and this low T4 normal TSH situation in premature babies can last up to 6 to 10 weeks. The last 15 years, it has been observed that many of the babies have late rise in TSH occurring at 2 weeks, 3 weeks, or even up to 5 weeks. And these babies belong to two categories. Either they were very premature, less than 30 weeks, or they had very low birth weight, less than 1.5 kgs. This is probably because of just a late manifestation of congenital hypothyroidism, the TSH coming up late, or it may be due to other factors like iodine exposure, congenital heart disease with its associated sick stage, and the exposure to contrast agents. Dopamine infusion, which is known to suppress the TSH, may be one factor, and sick state by itself can lead on to TSH suppression, which will rise after a few weeks. There are two uncommon thyroid function patterns which all of us should be aware of, and the first one is a low free T4 and normal low and rarely mildly elevated TSH situation, which is indicative of central hypothyroidism. And the baby may have features of hypopituitarism like micropenis or midline defects. And in turn, babies with low T4, normal free T4 with normal TSH, thyroid blinding globulin deficiency should be sought for. As all of you are aware of, most of the cases of congenital hypothyroidism are due to maldevelopment of thyroid or thyroid dysgenesis. And in minority of cases of dysgenesis, transcription factor mutations have been identified. The importance is that many of these transcription factors are associated with systemic manifestations. For example, NKX2 is associated with respiratory distress syndrome due to surfactant deficiency, PAX8 with urogenital tract malformations, FOXC1 is associated with cleft palate, spiky hair and corneal atresia, GLIF3 is associated with neonatal diabetes, and few of the transcription factors are also associated with congenital heart disease. Not uncommon syndromes like Down syndrome and DiGeorge are also sometimes associated with congenital hypothyroidism. Number of defects associated with decreased synthesis of thyroid hormones been recognized, put under the general category of dysharmonogenesis. And in the absence of maternal thyroid illness and drug exposure, fetal goiter would be suggestive of a dysharmonogenesis. And sensory neuronal hearing loss associated with pendrin mutations are well known to all of us. So it is important to be aware of these associations to think of the possibility of a dysharmonogenesis. Low free T4 with or without mild TSH elevation should bring in the possibility of central hypothyroidism, which may be associated with hypopituitarism. And this is an incomplete list of autosomally inherited transcription factors associated with hypopituitarism. And clinical clues would include ophthalmic abnormalities like microophthalmia or retinal dystrophy, single central incisor or micropenis. It is imperative to check all these patients for cortisol axis abnormalities and to start hydrocortisone before initiating LT4 therapy. Recently, it has been recognized that many of the patients have isolated central hypothyroidism, and the commonest defect associated with isolated central hypothyroidism is immunoglobulin superfamily member 1 defect. Others include TSH beta defect, TRH receptor defect, and transducin beta like factor 1 defect. So these are esoteric causes of isolated central hypothyroidism. Now let's look at the ISPA guidelines 2018. It starts off with estimation of TSH after 48 hours, preferably after 72 hours. And if the TSH is less than 20, it is considered as normal. Then if you happen to do the TSH between 24 to 48 hours, the cutoff is 34. However, it's sometimes very difficult to elicit the history of perinatal stress in newborns, at least for us endocrinologists. And it has been seen that even with patients less than TSH less than 20, a small percentage can eventually turn out to have congenital hypothyroidism. So any TSH above 10, it may be a good practice to repeat it a bit later. And for more than 20, things are pretty much clear, and it requires repeat estimation, venous sample more than 40. Then it's indication for treatment. So briefly, we take notice of TSH elevations more than 10. And we are concerned about elevations more than 20. So what is it about T4? We all know that T4 is higher in neonates. What is the definition or what are the cutoffs for low T4? So it is explicitly mentioned in the guidelines. Any value of less than 1.1 nanograms per deciliter free T4 or a total T4 of less than 8, irrespective of the TSH, should be taken as low, and TSH less than 1.17 and T4 less than 10 with TSH more than 20 also should be taken as low. So that is pretty much settled now. So when there is a low T4, the decision to start treatment is very clear. And if the TSH is high with a normal T4, then the TSH should be repeated after 2 weeks, and TSH more than 10 after 3 weeks is an indication to treat the patient at least till the age of 3 years. In normal T4 and TSH, then it goes down the pathway of normal interpretation of thyroid functions. So putting things together, there are these historical and physical examination clues which tells us about the probability of having a thyroid disease. And when then we look at the thyroid functions, TSH more than 40 with a normal or low T4 would be an indication for treatment. TSH more than 10 after 2 to 3 weeks with normal or low T4 is again an indication. And low free T4 with normal or slightly elevated TSH also merits treatment. The caveat would be premature and sick babies. So practically any TSH more than 10 before 2 weeks should be repeated. And in preterms, sick babies and babies exposed to iodine, repeat thyroid function at 3 weeks is mandatory. Helpful ancillary tests include ultrasound thyroid. For example, if it shows agenesis or ectopic thyroid gland placed in the higher up in the neck, that is pointed towards congenital hypothyroidism. Hearing test may show sensory neural deafness. Thyroglobulin levels may be low in thyroglobulin defects or in agenesis, and thyroid binding globulin is used to differentiate between central hypothyroidism and TBG defect. Technetium maybe thyroid scintigraphy is often useful and can help even if the ultrasound shows the gland. So absent or poor uptake may be a pointer towards acute iodine excess, NIS mutations or maternal inhibiting antibodies. Avid uptake is seen in iodine deficiency and dishormonogenesis. Perchlorate discharge test is a less often used test which is mostly done after the baby is a bit older and will establish the diagnosis of dishormonogenesis. Well, late onset hypothyroidism, which manifests after a few weeks with a late TSH elevation, and transient congenital hypothyroidism, which resolves by itself after few months or 1 or 2 years, are well-known entities. The factors associated include iodine deficiency, acute iodine excess, for example, contrast exposures, maternal antibodies, use of maternal antithyroid drugs, maternal toxicosis causing central hypothyroidism in the baby, TSH receptor antibodies which get transmitted from the mother, DUX mutations, and hemangiomas due to abnormal thyroid metabolism. So basically this is something which we already described. So there are some indicators of permanent hypothyroidism like family history, imaging not showing or showing ectopic gland, very high initial TSH, features of hypopituitarism. Then those patients are more likely to require treatment for life. And there are these patients in which the hypothyroidism can be transient, as discussed earlier, including preterm and sick babies, and these patients' thyroid function needs to be repeated. We now come to a rare entity, neonatal thyrotoxicosis, and most of the time is due to immune factors, TSH receptor activating antibodies transmitted from a Graves' mother. It can rarely be non-immune due to TSH receptor activating mutations, mecunalbrate, thyroid hormone resistance, and iodine use. So in the immune form of neonatal thyrotoxicosis is basically the interplay between thyroid stimulating antibodies and thyroid inhibiting antibodies, and a lot of factors like titers, affinity, half-life, and the maternal levels determine the fetal state, whether the fetus or the neonate is toxic or hypothyroid. It's important to recognize that in a Graves' mother, the first TSH which is done at 48 or 72 hours may not be suppressed if the mother was taking antithyroid drug and was euthyroid, or the normal TSH at birth can also be due to significant titers of TSH inhibitor antibodies. So the clinical clue would be partial or full remission of Graves' disease towards term in the mother. So that is one situation. So a TSH of less than or equal to 0.9 at 3 to 5 days when the mother has a history is suspicious for toxicosis, and after few days or few weeks the toxicosis can manifest. This may be due to shorter half-life of the thyroid receptor binding inhibiting antibodies. So after some time the stimulating antibodies start to manifest, and the toxicosis may last up to 3 months. So there are a lot of interesting situations which can occur here when a mother has a thyroid disease. It can be a central hypothyroidism, maternal toxicosis causing central hypothyroidism in the baby, TSH receptor inhibiting antibody causing primary hypothyroidism, and later on stimulating antibody causing toxicosis. So the dose of metimazole is recognized to be between 0.2 to 1 milligram per kg per day. So summarizing, when the TSH levels are borderline, we repeat the test at 2 to 3 weeks to make the decision. And in sick and premature babies, repeat testing is mandatory even if the first value is normal, and low T4 can be recorded up to 10 weeks. Neonatal toxicosis is a very rare entity but needs careful monitoring, decision making, and usually short period of drug therapy. Well, that's the end of the presentation. Thank you so much everyone for the patient hearing.